From the JAMA Network, this is JAMA Dermatology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Dermatology.
Hello and welcome to our listeners around the world. You're listening to JAMA Dermatology Author Interviews. Thanks for joining us. I'm Dr. Adamson, the web editor for JAMA Dermatology and host of this podcast episode. Skin cancer is one of the most common and costly skin diseases in the United States, affecting millions of Americans and costing billions of dollars each year. Public health campaigns have long focused on sun protection and UV awareness, but adherence to these measures can be low. This has sparked interest in additional preventative strategies such as oral chemopreventive agents. About a decade ago, the oral nicotinamide to reduce actinic cancers, or OnTrack trial, found that oral nicotinamide, a form of vitamin D3, was safe and effective in reducing new keratinocyte carcinomas and actinic keratoses in high-risk patients. Since then, many dermatologists have recommended nicotinamide, particularly for high-risk groups. However, large-scale real-world data on its effectiveness has been lacking. In a new study in JAMA Dermatology, researchers analyzed health records from more than 30,000 patients to assess whether nicotinamide supplementation reduces skin cancer risk in patients with a history of skin cancer and in solid organ transplant recipients. Dr. Wheless is a board-certified dermatologist and assistant professor in the Department of Dermatology at Vanderbilt University. He is also a staff physician at the Tennessee Valley Healthcare System VA Medical Center, both in Nashville, Tennessee. Welcome to the podcast, Dr. Wheless.
Thank you for having me, Dr. Adamson, and I'm excited to talk about our group's work.
I'm excited too, because I think that a lot of people will be interested in this topic. Vitamins to help reduce the risk of skin cancer. I mean, it's like almost the holy grail of prevention. You just take a pill and you reduce your risk of developing skin cancer.
That would be fantastic. I'm not sure that I'm quite ready to bank on that just yet, despite these great results. But certainly it was very compelling what we found.
Before we get into the data, how about you introduce yourself to the audience? What type of research do you do? Are you mostly a clinician? We'll start there.
Well, I am a medical and surgical dermatologist at Vanderbilt and the Nashville VA, as you mentioned. I have a PhD in epidemiology and a master's in clinical research. I'm currently funded through a VA Clinical Sciences Research and Development grant to look at the development of multiple skin cancers in veterans. And that's really been kind of the focus of my research team for the past, 5 to 10 years, is identifying these patients who are not just at risk for developing skin cancer in general, but the risk of developing multiple skin cancers. Because we know that a patient who has only one skin cancer, their outcome and morbidity and mortality is very different than a patient who develops 50 or 100 or more skin cancers. But when we just collapse all those down into a binary outcome, we're losing all those data. And this project was actually one that really benefited by getting that increased granularity.
There's been a lot of excitement around nicotinamide. You mind telling the audience, why? Why are all the, influencers and everyday dermatologists saying you should use vitamin B3 or nicotinamide for cancer prevention?
So back in 2015, there was a trial that you mentioned earlier in New England Journal that looked at the use of nicotinamide 500 milligrams twice daily on the ability to reduce skin cancer risk. And this was a neat trial in that they found that in patients who were taking nicotinamide, at 12 months, there was overall a reduced number of skin cancers in the nicotinamide group compared to the placebo group. Unfortunately, they did find that once patients stopped taking nicotinamide, they did see a trend towards a rebound in squamous cell carcinomas in particular. That was not significant. And then their follow-up study looked specifically at solid organ transplant recipients. Now, the authors themselves have discussed the multiple limitations with that project, first and foremost being slow recruiting, because everyone in their area was already on nicotinamide because they had done the prior study showing it worked so well.
and you're bearing the lead. That follow-up study was negative.
Correct.
This is in even higher risk population, right? People that have solid organ transplants. And it left a lot of people kind of scratching their heads like, okay, so it works in this population that are high risk, but not at the highest risk. But then in the highest risk population, those with organ transplant, they did not find a difference. But as you said, the trial was underpowered. And there was a lot of, contamination, as they say, because why not just take the vitamin, right? What's the downside? So we actually don't know the answer.
Exactly.
And so this is why you decided to do this study, right?
So this study actually was an outgrowth of, I had first gotten into looking at nicotinamide to respond to a project that had come out, I guess about a year and a half or 2 years ago now, looking at the metabolites of niacin and nicotinamide, suggesting that they had an increased risk of major adverse cardiovascular events. So your MIs, your strokes, things like that. I had been recommending nicotinamide to my patients for years, ever since that original New England Journal trial. And that scared me and a lot of my colleagues. And so we really needed to get an answer on that. And I won't take up all our time discussing what we found, but cut to the chase, we did not find evidence in two cohorts that was happening. However, that is a question that we absolutely need to get better molecular data on. And that'll be a discussion for another day. But after getting that paper out, a lot of the questions that I was getting from colleagues is, okay, great. We have good evidence that it's safe. Does it actually work? And I said, well, we've already got some of the infrastructure in place to do this study. Let's look at the efficacy of nicotinamide. And that's where this one really came from.
So we're going from it is efficacious in this high-risk group from the New England Journal paper from Australian group, On Track. And now we're using observational data in order to make inferences about whether it is effective or not. And doing that can create all sorts of issues related to, bias in many forms, whether it's like a mortal time bias or different confounders, all sorts of stuff. But it's one of the ways in which we can start to answer this question, is it effective or not? And so you mind telling the audience, like, how did you go about putting together this cohort so you could analyze this question? Because the data is probably a bit messy, although you use VA data, which is an advantage.
Yeah, we had a very, very large sample size. If you look at the On-Track trial, they had fewer than 400 patients enrolled. Our study, we had almost 34,000 patients. So very, very large sample. This is, I would wager, more patients on nicotinamide that have been reported in the literature combined up till now. So we had excellent power to look at any associations. But certainly, retrospective designs are extremely limited. And the one that we were most concerned about was, confounding on indication. There are no guidelines that tell us when we need to start nicotinamide. It's really just kind of a gut sensation of, this patient's they've had a number of skin cancers. Let's think about maybe starting nicotinamide in them. And so we had to do some fancy statistics / hand waving, depending on your perspective, to try and actually impute the baseline date of exposure for the unexposed patients. And so what we did with that was we really wanted to make sure that these patients are going to be at the same risk level for developing skin cancer as their matched exposed patients. And so we went through and we really tried to match on all the demographics, any kind of other chemopreventive that they might be on against skin cancer. So exposure to acitretin, anybody who's had field therapy with photodynamic therapy or 5-fluorouracil. We specifically did not include imiquimod because in the VA population, we do see a lot of veterans with warts who are being treated with imiquimod, and so it would be very difficult to tease out who is getting it for what indication. But also the biggest thing that we wanted to do was control for the rate and the number of skin cancers prior to exposure. We know that patients who have had a lot of prior skin cancers will develop the next skin cancer even faster. There was a great paper by Dr. Mackenzie Wenner back in 2015 or so, looking at the timing of subsequent skin cancers. And again, with each one of these, the time to the next skin cancer gets shorter and shorter and shorter. And so we know when you have multiple, you're going to be developing even more. And so we tried to match on not just the number of skin cancers that a patient has had, but the date of each individual skin cancer they had had before them to really get at that temporality. And if we saw a bunch of skin cancers clustered together over, a 1-year period, that we were getting that rapid increase in the rate of skin cancer development, not just, they've had 10 skin cancers over 20 years before exposure. Now, if they had 10 skin cancers in that 1 year prior to nicotinamide exposure, we wanted an unexposed control who also had that same number of skin cancers prior to exposure.
So if I were to paraphrase kind of how you designed this cohort, is what you wanted were as a group of people that develop skin cancer that have not been exposed to nicotinamide, and you wanted to match them with a group that had been exposed to nicotinamide. And you were very careful in that matching that you made sure the rate in which their skin cancer was getting matched, the date they got their skin cancers matched, their age, their sex, and all of these different variables that could possibly be different between the two groups, sort of to replicate kind of similar individuals and their only difference being exposure to nicotinamide or not. And as we talked about at the top, it's impossible to fully match on every single potential confounder, but you did your best.
Yeah, we certainly tried.
And the outcome of interest. So you matched these cohorts using what's called propensity matching. What was the outcome of interest?
So the outcome of interest was time to first skin cancer from the date of exposure from baseline. And now this is different than what was seen in the on-track and on-trans trials. Now, those two trials looked at the total number of skin cancers developed in the overall cohort. So they really were looking at the population level, whereas we were looking at the individual level. And a lot of this has to do with statistical power. Doing it at the population level and having a 1-year outcome like they used in the on-track and on-trans trials is definitely going to boost their power for the lower numbers that they had. Whereas we really were not limited by sample size. And so we were able to look at a far more granular individual level outcome. But another point about that is that when you're looking at population level sums of all of this, it can be very skewed by patients who have a high number of skin cancers. They could have had a single patient in there who developed 50 skin cancers within that year. And all of those are going to be added into that total sum and divided across all the patients that they had. In fact, I went and reread both of those papers, and nowhere do they discuss the actual number of patients who developed a skin cancer. They only talk about the total number of skin cancers. Now, I have for years crusaded on making sure we are reporting more than just skin cancer cases and the total number of skin cancers. So I'm not going to chide them for that. But it's a very important distinction between our outcome and the prior outcomes.
So you ran the numbers. What is the top level finding? Does nicotinamide reduce the amount of skin cancers overall and by different keratinocyte cancer type? And by how much?
Certainly. And so what we found was that overall, we did see a pretty significant reduction of skin cancers overall among the veterans in the study who were on nicotinamide. This was in line with the reported 30 to 50% reductions that have been out there before. But the bigger thing was that we also looked at the number of skin cancers prior to initiation of nicotinamide. And that's where it really got interesting, because we found that patients who started nicotinamide after a smaller number of prior skin cancers had a greater benefit than patients who started nicotinamide later after having developed, 6, 7, 8, 9, 10 or more skin cancers.
So what you're saying is if you developed a bunch of skin cancers, nicotinamide was less useful? Is this before taking nicotinamide or is this after?
So this is if somebody has developed, say, 8 skin cancers already, and then the dermatologist says, you know what, let's start nicotinamide, that patient is not going to be seeing the same kind of benefit as a patient who starts nicotinamide after taking it after 1 skin cancer.
Why do you think that's the case? Shouldn't nicotinamide help with the folks that are at higher risk? What do you think's going on there? And I would also push back and say, I think 8 previous skin cancers was the number in the on-track trial where it worked. What do you say to that?
So I'll take these in reverse order. Again, this is looking at
Individual
time
level.
to first skin cancer after versus total number of skin cancers at 1 year. And a patient who develops 8 skin cancers is very likely to be developing lots more skin cancers. And so if we are seeing a 30% reduction in that, 30% of 8 skin cancers over that year, that's going to be a decrease of 2 or 3 per patient. Whereas if this is a patient who's going to develop 1 skin cancer that year, it's going to be really difficult to pick up, 0.7 skin cancers. And so I think that might be part of what we're seeing. But also, if you think about the proposed mechanism of nicotinamide, which is it provides additional energy for cellular processes such as DNA repair, and it improves the efficacy of DNA repair, that patients on nicotinamide, when they're getting sun exposure, they're not getting as much DNA damage. That DNA damage then is not going on to form mutations. The DNA damage is also not triggering local immunosuppression in the skin. And those are the 2 big things that we know drive skin cancer in a lot of these patients. So then if we also consider once a patient has developed field cancerization, whereas they have developed just lots and lots of mutations throughout the skin, it takes very little additional damage to tip them over into developing skin cancers. And so if they've had lots and lots of skin cancers already and have that field cancerization, if we're improving the efficiency of DNA repair a little bit, again, it's kind of
The horse is out of the barn, you're saying.
Yeah, it's not going to be quite as effective because we're already there.
So first, did any of these results surprise you, 1? And 2, has this changed how you or who you recommend nicotinamide to?
So I was very surprised at the degree of difference that we saw across all the strata. I did not expect to see such a profound difference in patients who started it so early and see just a beautiful degradation of that benefit as we delay it for each subsequent skin cancer.
Yeah, if you look at the plots, the curves separate immediately. It's a little surprising.
It was. And I think a lot of that has to do, again, with to try and get at that baseline date for the unexposed patients, we had to use imputation. For a study of this size, there's really no way for us to go in and do the chart review and figure out, is the dermatologist recommending nicotinamide at this date or that date or whatnot? And so it was something that we know there's an issue with that. It's something that we're hoping that we can do a larger clinical trial to really follow up on this and get a better sense of the data.
Yeah, a prospective study.
Yeah, because this is one that when we stratified by the cumulative exposure to nicotinamide, we also saw that patients who were exposed to nicotinamide for greater than a year, there was separation between them and patients who are exposed to nicotinamide for only 30 days. We saw statistically significant separation even at 30 days. So we know there is something different between these populations because neither one of them has already been exposed to the cumulative amount, and there's already difference.
So you suspect maybe there's some confounding there, maybe.
There's definitely confounding there, but I think a lot of it is that we're really good at identifying who are high-risk patients. And we're starting high-risk patients on nicotinamide more frequently.
That begs the question then. Are you recommending this any differently now, today, than you were before you did this study?
I am. It's not the sort of thing that I'm saying everybody who gets their first skin cancer immediately needs to go on nicotinamide, but it really has shifted my thinking that if a patient has developed that field cancerization already, I really question, is this going to be as effective as if we had started before? Like, again, I think we're all really good at seeing that patient who they've got lots of AKs, they've had a couple skin cancers, and you can just get this sense that they are teetering on the edge of exploding with a number of skin cancers. I think this really pushes me to say, we need to start now and not wait for you to have that sixth, seventh, or more skin cancer before we start doing something preventive.
So there's a lot of different ways you can interpret this data because it's observational. And there's no causality that we can infer. And it then necessitates that we do a prospective randomized trial to see, if these actually hold up under that scrutiny. Would you agree?
Oh, absolutely. And I'm actively on my computer right now. I'm working on the draft for doing the trial. So hopefully we can get a large cooperative study that has a good enough sample size that we can look at this type of stratification and have power to be able to find any kind of significance.
I could keep talking about this trial for a long time, but we need to end the podcast here. Thank you so much for being on the podcast, Dr. Wheless.
Well, thanks for having me.
I am Dr. Adamson, and I've been speaking with Dr. Lee Wheless about nicotinamide for skin cancer chemoprevention in a real-world cohort. You can find a link to the paper in this episode's description. This episode was produced by Daniel Morrow at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening. Catch you on the next episode of the JAMA Dermatology Podcast.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.